So we now move on to Chapter 15, Cannabis. The learning objectives are to explain the relationship between marijuana and cannabis, to describe the different preparations of cannabis and their THC concentrations, to describe the use of cannabis throughout history, to describe the supply, distribution, and trafficking of marijuana, hashish, and hash oil in Canada, to discuss the prevalence of cannabis use in Canada, to describe the pharmacological properties of cannabis, to describe the medical conditions for which marijuana has demonstrated effectiveness, to describe the causes of concern associated with the use of cannabis, to describe the implications of cannabis use in a Canadian setting. So marijuana is classified separately because its effects are complex. It has some sedative-like effects, provides some pain relief, and in large doses has hallucinogenic effects. The effects it produces in most users are sufficiently different from the effects of depressants, narcotics, and hallucinogens to merit its classification as a separate substance. Marijuana is the leafy material from the cannabis plant that is smoked. There is some question over whether there is more than one species of cannabis. Evidence suggests that there are 3 species. One is Cannabis sativa. It originated in Asia, but is now grown worldwide. It's primarily grown for its fibers, from which hemp rope is made. It grows as a weed in Canada and the US, and it is a lanky plant up to 5.5 meters high. Cannabis indica, it's grown for its psychoactive resins. It's cultivated in many areas of the world, including many backyards in Canada. It's a compact plant, usually only 1 meter high, and its potency varies depending on plant genetics and environment conditions. And lastly, there is Cannabis rudularis, and is grown primarily in Russia and not at all in North America. So we look at cannabis preparations. The primary psychoactive agent in cannabis is delta-9 tetrahydrocannabinol, or THC. THC is concentrated in the resin, most of which is in the flowering tops. It's less in the leaves, and little is in the fibrous stalks. The psychoactive potency of cannabis preparations depends on the amount of resin that is present. Cannabis preparations available in Canada. Its most potent form, known as charas, and it consists of pure resin carefully removed from the surface of leaves and stems. And hashish, in its purest form, is just pure resin. The second most potent preparation is ganja. It consists of dried flowering tops of the plants with pistillate flowers, or female plants. Male plants are removed from the fields before the female plants are pollinated and begin to put their energy into seed production, thus increasing the potency of female plants. The results is high-grade marijuana called sinsemilla, from the Spanish sinsemilia, or without seeds. The weakest form, bang, is grinding up the entire plant once the top has been removed. It's actually rare in Canada, but about equivalent to low-grade marijuana consisting of leaves of the plant. And some contain less than 1% THC. And lastly, we have red oil of cannabis. It's done by manually scraping resin off the leaves, and it's tedious, and more efficient methods of extraction exist that result in producing potencies greater than 50%. And so here we have, hashish, which consists of pure resin that has been carefully removed from the surface of the leaves of the stems, and it may be less than pure, depending on how carefully the resin has been separated from the plant material. The average THC content of hashish ranges from 3 to 8%, and there are a few batches have tested as high as 20% THC. When we look at production methods, the traditional production involves manually scraping in hashish of excluding resin from the plant. More efficient recent production methods have involved boiling the plants in alcohol and evaporating the resulting liquid down to a thick, dark hash oil. The potency of hash oil varies, but can contain more than 50% THC. When we look at sinsemilla, it consists of dried flowering tops of plants with postulate flowers or female plants, and the male plants are then removed from the fields before the female plants are pollinated. Female plants don't put their energy into seed production and thus increasing their potency. And the average THC content of sinsemilla samples is about 7 to 12%. And bang consists of the remainder of the cannabis plant after the top has been picked. The plant material is dried and ground into a powder and mixed into drinks or candies. It's rare in Canada, but equivalent to low-grade marijuana consisting of just the leaves. And the average THC content is less than 1%. So when we look at the history of cannabis, the first mention is in a Chinese pharmacy book dating back to 2737 BC. And so that's the third millennium. Okay. Social use of the plant had spread to the Muslim world and North America by 1000 AD. There was a story, the Hashishiya, religious sect that carried out political murders. And there's also a story of cult spread by Marco Polo in 1299 and Boccaccio in 1350s. Is the possible origin of the term assassin. And hashish, use was mentioned frequently in the Arabian Nights. And then we look at, in the 19th century, Romantic literature and the new science of psychology. Napoleon's campaign to Egypt at the beginning of the 19th century increased the Romantics' acquaintance with hashish. In the 1830s and 1840s, anyone was thinking about using, or decrying the use of mind-tickling agents such as opium or hashish. And one of the earliest, in 1844, popular accounts of the use of hashish is in the Count of Monte Cristo by Alexander Dumas. Well-known writers, in Gautier or Dumas wrote about, the kind of effect that you would expect from imbibing in hashish. So you can see that throughout even literature, there was a long history of cannabis use. And we normally see that historically a lot in the literature. So when we look at, the history of cannabis policy in Canada, Chapter 3 did provide a broad discussion pertaining to the history of drug regulation in Canada, with specific reference to the evolution of laws and policies related to marijuana. But, since the passage of the Opium Act in 1908, Canada had the strict drug control policy. And then for most of the 20th century, Canada's illicit drug policy have been one of the most punitive drug control systems in the world. So we look at, the history of the legalization of cannabis in Canada, the marijuana supply, distribution, and trafficking in Canada. We need to take a look at that. And the background really is that marijuana is cultivated in both indoor and outdoor grow operations. And, indoor production sites are more common because the greater control over the growing environment results in larger yields and higher THC levels. And increasingly sophisticated indoor cultivation methods have contributed to higher THC levels. And we see that from, what is available today, that the THC content in cannabis is much, much higher than maybe what our parents would have been used to. Increasingly sophisticated indoor cultivation methods are directly contributed to that higher THC level. And the amount of marijuana produced exceeds domestic demand, resulting in export to foreign markets, most notably to the United States. According to the 2009 report on illicit drug situation in Canada by the Royal Canadian Mounted Police, the amount of marijuana, again, that exceeded domestic demand, and it resulted in organized crime, producing it for the export to the foreign markets. And, cultivation and production predominantly was in the provinces of British Columbia, Ontario, and Quebec. So here we have an example of an outdoor marijuana grow operation. You can see, how remote this would be, and how sophisticated some of those grow operations would be. And this is from the Royal Canadian Mounted Police at the time. Just to give you, some context, Canadian law enforcement seized 34,000 kilograms of marijuana and 1 million marijuana plants just in 2009 alone. And so hash and hash oil smuggled into Canada, it really originated mainly from South Asia, the Middle East, Africa, and the Caribbean. Morocco is the largest supplier of hash to the global market at this time. And Pakistan remains one of the primary sources or transit countries for hash destined for Canada. Jamaica also had been the primary supplier of hash products, especially hash oil, to Canada, earlier on. So when we look at Bill C-45, an act respecting cannabis and to amend the Controlled Drugs and Substances Act, the Criminal Code and other acts was introduced in the House of Commons on April 13, 2017. The Government of Canada's goal for legalizing, strictly regulating, and restricting access to cannabis is to keep cannabis out of the hands of Canadian youth and to prevent organized crime from continuing to profit from the illegal cannabis market. And so the Cannabis Act, which came into force on October 17, 2008, legalized recreational marijuana. So when we look at the prevalence rates of cannabis use in Canada, some of the background, the Canadian Tobacco, Alcohol and Drug Survey is an ongoing general population survey of alcohol and illicit drug use among Canadians 15 years and older, and is designed to provide detailed national and provincial estimates of alcohol and drug-related behaviors and outcomes. Prevalence rates, when we look at cannabis, are significantly higher in males than in females across Canada. And there were statistically significant decreases in past year cannabis use use every year over the last 5 years within the age category of 15 to 24. So here you can see, a slight decrease and then increase, but, when we look at the ages, we are seeing some decreases overall year over year. And so, what does Canada's youth really think about cannabis from that survey? So cannabis is one of the most commonly used illicit drugs among Canadian youth, age 15 to 24. And the Canadian Centre on Substance Abuse conducted a study to examine youth perceptions and decisions regarding cannabis use. The focus group had 76 youth, aged 14 to 19, from 5 Canadian cities, and it revealed 5 themes. The first was influences for smoking and not smoking, where peer pressure, social connectedness, and the drug's perceived availability and popularity were the factors that were associated with youth's decision to use cannabis. Secondly, there was a perceived positive and negative effects of cannabis use. Youth in general perceived more positive effects than negative ones, and positive effects were attributed to cannabis use that included helping one to focus, relax, sleep, be less violent, and more creative. Thirdly, when we look at the perception that cannabis is natural and safe and not a drug, many youth noted that they did not believe cannabis to be a drug and it is a natural substance and non-addictive, and they believed cannabis to be much less harmful than alcohol or tobacco. Fourthly, when we look at cannabis and driving, opinions pertaining to driving under the influence of cannabis were varied in that survey. Even those opposing to driving under the influence of cannabis believed it less dangerous than driving under the influence of alcohol. And lastly, the legality of cannabis. Youth were uncertain about the legality of cannabis use. So now we look at worldwide use of cannabis. The United Nations Office on Drugs and Crime estimates that between 155 million and 250 million people use illicit substances at least once in 2008. Globally, cannabis users are the largest number of illicit drug users. Globally, annual cannabis use is estimated between 2.9% and 4.3% of the population aged 15 to 64. And you can see here on this chart the global estimates of illicit drug use when it looks at regions, and we're looking at cannabis in the in the oceanic provinces, territories, 2.1 to 3.4%. But globally, you're looking at 128.9 to 190.8 number of users. And these are millions. Africa at 27.7 in Africa. And we see that being higher than all the other opiates, cocaine, amphetamines, and ecstasy. We look at compassion clubs in Canada. Compassion clubs are self-regulated, and there are no federal standards on which they operate to produce and distribute marijuana. Health Canada is the only organization that can supply individuals with seeds or dried marijuana for medicinal purposes. Compassion clubs operate outside of Canadian laws, and the purchase of marijuana through these clubs is subject to law enforcement measures. Now, when we now look at the pharmacology and cannabinoid chemicals, the chemistry of cannabis is complex and unique. The active agent contains no nitrogen and thus is not an alkaloid like other psychoactive plant materials. And cannabinoids comprise 70 chemicals that are unique to the cannabis plant. And so delta-9 tetrahydrocannabinol, or THC, is isolated and synthesized in 1964, is the most pharmacologically active in the cannabinoid plant. And, really, when we look at that, there may be several other active agents in cannabis as well. So here you see, the delta-9 THC. It's the most psychoactive substance found in cannabis. And, it's isolated from brain tissue there. We can see the difference between the two. And so when smoked, THC is absorbed rapidly by the blood and travels to the brain and then to the rest of the body. Within 30 minutes, much of the THC is gone from the brain at that time. So peak psychological and cardiovascular effects occur together within 5 to 10 minutes. Following oral ingestion, THC is absorbed more slowly and the liver transforms it into 11-hydroxy-delta-9 THC. Less THC at that point reaches the brain, and the peak effect occurs about 90 minutes following ingestion. And so metabolites have different half-lives, and after 1 week, 25 to 30% of the THC in its metabolites might remain still in the body. It may take 2 or 3 weeks to completely eliminate a large dose of THC and its metabolites in the body. And really that is due to the high lipid solubility of THC and its metabolites, and it means that it is selectively taken up and stored in the fatty tissue to be released slowly. There's no easy way to monitor THC or metabolite levels and relate them to effects as can be done with like blood or alcohol concentration. And so long-lasting low concentrations of THC and its metabolites may have effects on the brain and other organs that have not yet been determined. And so we look at the mechanism of action. Research into the action of marijuana on the central nervous system leads to the discovery of the endogenous substance anandamide that has marijuana-like effects when administered to animals. And so anandamide, has endogenous substance, and it's isolated from brain tissue with marijuana-like effects, and it's from the ananda, or Sanskrit for bliss. And so THC and other cannabinoids bind to two receptors, the CB1 receptor and the CB2 receptors. CB1 receptors are found primarily in the brain, but are also widespread throughout the body, more so than receptors for other drugs. And its potential actions of cannabinoids are widespread. And so high density of CB1 receptors in the basal ganglia, that's responsible for movement or coordination, and the cerebellum, which is fine body movement and coordination, the hippocampus, memory storage, cerebral cortex, when it comes to higher cognitive functions, and the nucleus accumbens, which is our reward center. Okay. And so, the many actions on the CB1 receptors are quite widespread. We're talking about coordination, we're talking about memory, we're talking about higher cognitive functions, and our reward center. Then we look at the CB2 receptors. They're found mainly outside of the brain in the immune cells, and the potential role of cannabinoids in the modulation of the immune system are where the effects there are felt. And so here we have, when marijuana, hashish, or hash oil is ingested, the psychoactive ingredients in these preparations, delta-9 THC, produces the effects through the activation of or binding to the cannabinoid receptor CB1 in the brain. And these CB1 receptors are widely distributed throughout the brain, but are found especially in areas responsible for the regulation of movement, coordination, learning, memory, and higher cognitive function. So, cannabis does have a lot of effects on the brain. So when we look at the physiological effects of cannabis, and specifically the cardiovascular effects, cannabis will increase heart rates that occur after smoking marijuana and ingesting oral THC. And research on cannabinoids on blood pressure have been mixed. There are cardiovascular risks of marijuana use that haven't really been shown in youth or healthy users. And people with cardiovascular disease should probably avoid marijuana or an oral THC due to its effects on heart rate. When we look at the pulmonary effects, bronchodilation is seen following acute exposure to marijuana. And so heavy marijuana smoking over a long period could lead to clinically significant impairments in pulmonary functioning. Also, there is the physiological effects of reddening of the eyes and the dryness of the mouth and throat. And so, the time course for heart rate after smoking marijuana on the left and ingesting oral THC, and you can see the ingestion does take longer for the physiological effects to decrease. We're looking at 240 minutes overall, whereas, the time is much, much less when it comes to smoking marijuana. So when we look at the abuse potential has been shown. Studies show both animals and humans will self-administer the drug, and marijuana cigarettes with higher THC content are preferred. Oral THC does not have high abuse potential, likely due to its different time course, and the less rapid onset of effects is usually associated with reduced risk of abuse. And so when we take a look at the behavioral effects, really we're looking at self-administration. Marijuana is robustly self-administered by humans. And marijuana self-administration is related to the THC content of cigarettes, suggesting that THC administration alone might have abuse potential. Whereas, oral THC does not have high abuse potential, possibly due to its different time course, less rapid onset, and effects is usually associated with reduced risk of abuse. Now, when we look at the subjective effects, the effects include, euphoria, high, mellowness, hunger, and stimulation. And the peak effects occur within 5 to 10 minutes after smoking and last for about 2 hours. Infrequent smokers do report similar but more intense effects compared with experienced smokers because they have less tolerance to marijuana-associated effects. And so really at high THC concentrations, infrequent smokers may report negative effects such as mild paranoia and hallucinations. So regular marijuana smokers can recognize the difference between real and placebo marijuana cigarettes. And oral THC has similar subjective effects, but with a different time course. And so experienced marijuana smokers report euphoria, high, hunger, and mellowness after smoking. The magnitude of the effects depends on the THC concentration. So when we look at the cognitive effects of cannabis, acute administration of smoked marijuana to infrequent marijuana users disrupts cognitive performance. It slows cognitive processing. It impairs short-term memory. It impaired inhibitory control. It had the effect of a loss of sustained concentration or vigilance, and impaired the visuospatial processing. And so acute administration of smoked marijuana to frequent marijuana users cause less dramatic effects, implying that they are tolerant to some, but not all, the cognitive effects. They still showed slowed cognitive processing, consistently seen, and impairment during certain workplace tasks and the operation of machinery and automobiles can have significant effects. So we look at long-term cognitive effects. Really, the effects of long-term cognitive functioning are more difficult to predict. Studies have had divergent findings and interpretations. And so current evidence suggests that after abstaining for more than a month, regular marijuana use produces few effects on cognition. And additionally, better research may change that current thinking at that time. But recent studies have combined cognitive testing with neuroimaging, and subtle brain activation differences may have little impact on behavior. And it is advised to first carefully examine the major behavior of interest, which is really cognitive performance. When we look at the appetite, marijuana and oral THC significantly increases total daily caloric intake. And these findings have contributed to the clinical use of cannabis-based drugs for appetite stimulation. But it is unclear if average chronic marijuana users are overweight. And lastly, verbal behavior. Marijuana use results in a dramatically decrease in verbal exchanges and an increase in nonverbal social interactions. So when we move on to looking at the medical use of cannabis in Canada, some of the background, the oral form of synthetic THC, dronabinol, 2.5, 5 or 10 milligrams dissolved in sesame oil in capsules, is marked in Canada and the United States as Marinol. And Sativex is marketed in Canada as an adjunctive treatment for the symptomatic relief of neuropathic pain in adults with multiple sclerosis. It is marketed as an adjunctive analgesic in adults with advanced cancer experiencing moderate to severe pain during the highest tolerated dose of strong opioid therapy for persistent background pain. And Nabalone is a synthetic cannabinoid with antiemetic properties that have been found to be of value in the management of nausea and vomiting in patients undergoing chemotherapy. So Health Canada document information for healthcare professionals, cannabis, and the cannabinoids kind of talks about patient claims that smoked cannabis relieved chemotherapy-induced nausea and vomiting, and is widely recognized. And cannabinoid CB1 and CB2 receptors have been found in areas of the brainstem associated with emetogenic control, which helps with nausea. And the use of cannabinoids is currently considered a fourth-line adjunctive therapy in chemotherapy-induced nausea and vomiting. And so more research is required to determine if combination therapy provides added benefits above those observed with newer standard treatments. So there is strong evidence that the endocannabinoid system plays an important role in the modulation of pain. Elements of the endocannabinoid system found in the supraspinal, spinal, and peripheral levels of the pain pathways. And so randomized double-blind placebo-controlled studies suggested oral THC or provides an analgesic effect in people with moderate to severe continuous pain caused by advanced cancer. And marijuana, for the purpose of regulation, allows the use of dried marijuana in cancer patients experiencing severe. And anecdotal reports have suggested that marijuana can alleviate symptoms of spasticity and provide relief and improvements in sleep for patients suffering from multiple sclerosis. While there are benefits for the management of glaucoma, there have been no recommendations from the Canadian Ophthalmological Society or the American Glaucoma Society. And historically and anecdotally, there is evidence for the treatment, evidence for asthma as a result of that. And so, there are several other, incidents of using cannabis, most notably wasting syndrome in AIDS and cancer patients. So appetite stimulation and weight gain for people with AIDS was shown in the research and was used widely. Epidemiological studies suggest that people using marijuana have higher intakes of energy and nutrients than non-users. And controlled laboratory studies with healthy subjects suggest exposure to marijuana correlates positively with an increase in food consumption, caloric intake, and body weight. And, oral synthetic THC administered as capsules it was approved, and it really does help with stimulation of appetite. And so appetite stimulation and weight gain in people with cancer, anorexia is one of the more troublesome symptoms associated with cancer. While it is anecdotally known that smoking marijuana can stimulate appetite, the effects of smoking marijuana on appetite and weight gain in patients with cancer have not been quite studied as much, and the results from the trials are mixed. When we look at anorexia nervosa, the endocannabinoid system has been implicated in appetite regulation and is suspected to play a role in eating disorders, but little information exists on the use of marijuana to treat anorexia nervosa. When it comes to multiple sclerosis, other public reports suggest that people with plasticity may experience relief with cannabis, and people with MS report using cannabis to manage such symptoms as spasticity and chronic pain, as well as anxiety and depression. Patients also reported an increase in their sleep. And reputed dosages of smoked cannabis by these patients varied from a few puffs to 1 gram or more at a time. And amyotrophic lateral sclerosis, the endocannabinoid system has been implicated in the pathogenesis of ALS. And under certain conditions, cannabinoids have been reported to delay disease progression in ALS patients and prolong survival in mouse models of ALS. But there are a few clinical trials of cannabis for the treatment of ALS at this time, and it exists, and the results of the studies are mixed. Now, when we look at epilepsy, there is increasing evidence that points to a role in the endocannabinoid system in the modulation of neural tone and excitability. And so epileptic activity is associated with changes in the CB1 receptors in the hippocampus. And so reduced levels of the endocannabinoid anandamide have been detected in the cerebrospinal fluid of patients with untreated newly diagnosed temporal lobe epilepsy. So although cannabis can reduce seizure frequency in some cases, but it can actually provoke seizures in others. And so while current scientific evidence is not conclusive in marijuana for medical purposes, regulation allows for the use of dried marijuana in the context of epilepsy in patients who have either not benefited from or would not be considered to benefit from conventional treatments. And so, pain from cancer, few properly controlled clinical trials of smoked marijuana for the treatment of cancer pain have been conducted. In Canada, Sativex is approved as an adjunct analgesic for cancer pain in adults with advanced cancer who experience moderate to severe pain, even with the highest tolerated dose of strong opioid therapy. So we look at psychiatric disorders. Historical claims purport that cannabis may be beneficial to persons suffering from anxiety, depression, sleep disorders, and withdrawal from alcohol and opioids. But there is insufficient evidence that exists to support these claims, and clinical trials with oral THC have shown either a lack of effect or worsening of anxiety or depressive symptoms overall. And so again, for glaucoma, THC and cannabinoidol may have neuroprotective effects that could also be useful in the management of glaucoma. And cannabinoid-based therapy is limited by the short duration of cannabinoid action and unwanted psychotropic and physical effects. So when we look at the contraindications, marijuana is counterindicated in persons under the age of 18, anyone with a history of hypersensitivity to cannabinoids, people with liver, kidney, cardiopulmonary disease as a history of psychiatric disorders, or particularly schizophrenia, and women of childbearing age not on a reliable contraceptive, as well as those planning pregnancy and those who are pregnant or women who are breastfeeding. Marijuana is men intended to start a family. Marijuana may also exacerbate the CNS depressant effects or sedatives, including alcohol. And concomitant use with other drugs may increase the incidence of adverse effects. So there are some causes for concern. The euphoric effect produced by cannabis is not as intense as the produced by the other psychoactive drugs such as cocaine or heroin. Cannabis use does possess dependency syndrome and withdrawal symptoms with cessation or frequently high potency use. And so the DSM-5 doesn't recognize a diagnosis of cannabis withdrawal. But data from a variety of studies suggest an abstinence syndrome does exist. It's not life-threatening, but it is unpleasant. And withdrawal symptoms can include negative mood states, anxiety, irritability, disruptive sleep, decreased food intake, and in some cases aggressive behavior. And it begins about 1 day after the last dose and lasts 4 to 12 days. Intolerance, may not develop uniformly to all effects. Intolerance to marijuana effects develops after regular use of high levels. So relative to other drugs of abuse, many people receive marijuana to be an innocuous drug with limited abuse potential. And again, that tolerance to many marijuana effects develops after regular use of high levels. Marijuana has abuse potential, and, it should be noted, and a significant minority of current marijuana users may be abusing or depending on the drug. And toxicity potential. So there are acute physiological effects. When we look at primarily increased heart rate, no human overdose deaths have been reported, but cannabis overdose does not appear to be an important public health issue at this time. When we look at driving ability, though, research findings are mixed on whether marijuana impairs driving. Epidemiological studies have found little evidence that drivers who use marijuana alone are more likely to be involved in an accident, whereas computer-controlled driving simulations show that marijuana produces significant impairment, and effects may be more severe in infrequent users. And so there we have, the laboratory studies on computer-controlled driving stimulation show, that show a significant impairment, and the effects again are more severe in infrequent users. And so these are estimates of the number of victims and associated cost of cannabis-related collisions. And so, there are costs associated with it, and there are deaths that are associated with impairment and marijuana use. And so, there are panic reactions as well, and panic reactions are a major behavioral problem associated with acute marijuana intoxication, and the panic reaction is usually fear of the loss of control and fear of things that will not return to normal, and that can have quite an effect on the cannabis user. Chronic lung exposure. Chronic daily smoking of marijuana impairs airflow in and out of the lungs, but the long-term implications for health are unclear. A recent study did find that marijuana was not associated with an increase of respiratory symptoms or lung disease, and there's no direct evidence that marijuana smoking causes lung cancer. Marijuana smoke does contain, however, carcinogens. Most regular marijuana users smoke fewer marijuana cigarettes than tobacco users smoke standard cigarettes. Marijuana users typically hold smoke in their lungs longer than do cigarette smokers. And marijuana cigarettes are not filtered in the same way that tobacco cigarettes are. We look at reproductive effects. Marijuana can cause reduced testosterone levels, diminished sperm counts, and abnormal sperm in men. And there is a growing number of studies that have shown marijuana used by pregnant mothers does not appear to be associated with lower birth weights or premature birth. However, amounts of marijuana used by these mothers were relatively low in that study, and it's wise to avoid all drugs during pregnancy. When it comes to the immune system effects, there is some evidence that marijuana use reduces immunity to infection. And mortality data has not shown a relationship between marijuana use and overall death rate. When we look at amotivational syndrome, research does not support the hypothesis that frequent marijuana users exhibit diminished motivation. And the laboratory does not support that at this time. And there used to be a concern has been expressed about the effects of regular marijuana use on behavior and motivation. reefer madness, marijuana madness. Some researchers are collecting data that they claim shows that marijuana causes psychosis. And some studies have found a correlation between marijuana use and psychotic symptoms. And the participants admitted to having at least one psychotic symptoms in the study. And it is possible that people had psychotic symptoms prior to using marijuana. And since marijuana users typically use other psychoactive drugs, it is difficult to disentangle the influence of other drug use on the psychotic symptoms. And there is evidence that marijuana can increase the likelihood of psychotic episodes in individuals with a history of psychiatric problems. And lastly, we look at synthetic cannabis. Synthetic cannabis, the devil you know or the one you don't. A new generation of synthetic cannabinoid agonists has been reported to be used recreationally. Products are marketed as natural, herbal, incense, or potpourri, and under various brand names such as Spice or K2, and have been sold legally in head shops, convenience stores, and through the internet to those seeking the marijuana-like high. And there is real concern, however, that synthetic cannabinoids may cause negative effects on human health, but it is not widely studied at this time. And there is growing evidence that, that the average content of THC cannabis is increasing, and the negative effects of cannabis use presumably are related to THC content. And so cannabinoid, another constituent in cannabis, has been shown to have anxiolytic and antipsychotic effects. Just as there is a variability in the THC content of cannabis, so too is there a variability in the cannabinoidal content of cannabis. And so cannabidiol may offset some of the adverse effects of THC. And if cannabidiol offsets some of the negative effects of THC, then exposure to cannabis with higher THC content or low cannabidiol content might be associated with greater negative consequences. And some experiment evidence has supported this hypothesis. And so really, in summary, cannabis has a rich history of medicinal and recreational use. There are 3 species of cannabis: Cannabis sativa, Cannabis indica, and Cannabis ruderalis. And the chief active component is THC. THC is absorbed rapidly by smoking, but slowly and incompletely when taken orally. THC has a long half-life of elimination of its metabolites and may remain in the body for several weeks. Selective THC receptors exist in brain tissue, leading to a natural brain cannabinoid anandamide. THC has sedative, analgesic properties in high doses, in high doses hallucinogenic effects. Cannabis is the most widely consumed illicit drug in the world. Hash and hash oil smuggled into Canada originates mainly from South Asia, the Middle East, Africa, and the Caribbean. THC and other cannabinoids bind to 2 receptors, designated CB1 and CB2, found primarily in the brain. Highest density in cells are found in the basal ganglia. Marijuana causes an increase in heart rate and reddening of the eyes. Medical marijuana has helped individuals with cancer, AIDS, multiple sclerosis, and glaucoma. Sativix is marketed in Canada, and it's an adjunct treatment for neuropathic pain in adults with multiple sclerosis, as an adjunctive analgesic in adults with advanced cancer. Nabilone, a synthetic cannabinoid with antiemetic properties in the management of nausea and vomiting associated with chemotherapy, and strong evidence and withdrawal not common but can occur. Cannabinoid withdrawal symptoms are negative mood states, disruptive sleep, decreased food intake, and aggressive behavior. Marijuana has been found to impair driving skills, and long-term effects can include a sense of listlessness and general apathy. There have been no human deaths reported from overdose of cannabis, and the administration of marijuana and cannabinoids to rodents causes a reduction in neuron density in the hippocampus. The relationship between substance use and psychotic illness, there is a relationship, a causal relationship between cannabis use and psychosis, though cannot be excluded. Cannabinol, another constituent of cannabis, has been shown to have anxiolytic and antipsychotic effects. And that is the end of the chapter on cannabis.